Good morning. My name is John Dumot, and I'm coming to you from Cleveland, Ohio. I would like to thank Lena Katan and the SAGES committee for allowing me to share with you some ideas and thoughts on endoscopic resection. Today, we're going to discuss the difference between EMR and ESD and how it may apply to your practices. I have to get this on full screen. My disclosures: I work with US Endoscopy, which I've received consultant fees to design and give feedback on colonoscopy snares, which is the only topic that applies to this talk. I think it's important for us to review high quality colonoscopy issues, and then we'll go right into endoscopic resection with mucosal resection technique versus submucosal dissection. And then we'll cover the guidelines for follow-up and surgical intervention for large polyps. I assume that all of you do surgery and the majority of you do colonoscopy. And so I'd like to start off with what we're not talking about today. We're not talking about an advanced adenoma that's pedunculated. We're not talking about a malignant polyp. And we're not talking about a sessile adenocarcinoma that could be termed laterally spreading tumor. I'll point out here in the first picture, there is a granular appearance to this advanced adenoma, meaning that we do see pit patterns and we do see vasculature. This polyp should be removed with hot snare or cold snare technique. This malignant polyp would be entirely cancer. Surgical intervention is advised. Routine biopsies to be sure you have the diagnosis is absolutely imperative. This last lesion is a little trickier. The entire lesion itself is malignant. You would be able to tell that by the non-granular appearance, the firm mass-like structure when it's touched. It's going to be fixed to the wall, and no one needs to inject underneath this to prove that there is submucosal invasion. There's nothing on here that endoscopic resection could help. So issues in colonoscopy, the shortcomings should be at the top of everyone's mind, in my opinion. Bowel preparation is paramount. I consider this a team sport. Starts with my office and discussion with the patient about their options for bowel cleansing material and solutions. I don't think that you should put down that you have a good or adequate bowel rating unless you really do have a good or excellent bowel rating of the entire colon. This should be what you have achieved after lavage, not what you found. And avoid the term adequate unless you're doing a therapeutic procedure. I think it'd be reasonable for the bowel prep to be not spectacular, but for a screening exam, you really need to have a good or excellent bowel preparation rating to follow the guidelines. It's that interval cancer that we all worry about. Cecal innovation should occur at a very high level. We're talking over 90%. Over 95, 96%, or 98% in excellent hands. Some people using advanced techniques to get to the cecum. The photo documentation is important, although GI Quick only requires it in the cecum and the rectum. I think all segments should be photographed. Your careful withdrawal time is a minimum of 6 minutes on average. We encourage gastroenterologists to withdraw up to 8 minutes in time. We don't count off time for removing polyps. Ideally, you're going to identify and deal with all neoplasms, and you should really know the difference between your adenoma detection rate and your mean adenoma detection rate, so you can avoid the one and done syndrome. Informed consent is also a big issue in my opinion. This can be difficult in open access. I tell my schedulers to chat the patient up and try not to schedule a procedure before a big event. I don't dwell on the complications. I tell patients that they're going to have a chance of bleeding, infection, or perforation, but it's quite low in a screening colonoscopy based on Medicare data. It's probably around 2 to 3 out of 1,000. Now that goes up dramatically for large polyps, 2% for EMR and 2 to 10% for ESD. On the other hand, they're balancing the risk with the benefit, and most benefits and most complications are related to the polypectomy itself. And again, I tell the patient what I want them to know. Early on, there could be complications. I tell them I don't want to leave the endoscopy unit if they don't feel well. And I pretty much do that as I'm examining the abdomen. Beware of the bum's rush that can occur in the PACU area. Sometimes the unit is full and they're trying to get people moving along and they may not be completely awake. I also tell them, and it kind of surprises them, I say, don't call me if you start bleeding after you leave. I don't want them to call me. I can't do anything over the telephone. I tell them to go to the emergency room. They all leave with a copy of the report, and then from there, the emergency room will call us. The complications that do occur must be dealt with and managed as a team. Often I'm asked to intervene or comment on some disagreement about how it's documented in the chart. And post-polypectomy syndrome is a spectrum. This varies from a submucosal or a serosal burn to frank air in the peritoneum with a leak. Antibiotics and bowel rest, as you know, are important. Surgery should be uncommon if you're working together. And post-polypectomy syndrome is not related to improper technique in the majority of cases, in my opinion, although it can be, and we'll go over some of that. Individualize your anticoagulants. Do not stop aspirin. For the most part, try to use cold snare technique to avoid cautery injury to the submucosal vessels, and clip closure is likely beneficial for polyps greater than 2 centimeters on the right side. Outside of that area, they're probably not beneficial. In terms of the excellent high quality colonoscopy, don't forget about the serrated polyps. These are a little difficult to see. If the bowel prep is actually too good, you'll miss the mucus cap. Get your snare around that area and withdraw some of the normal tissue right around there, looking for this submucosal cord. The prevalence can be as high as 8% for high ADR physicians. Previously, it was thought to be quite low. The key here is many of them, over 60% of them, are larger than a centimeter. So I believe that the majority of our interval cancers are coming from serrated adenomas that were not identified. So how about large polyps, and what are my steps for removal? Well, the first step is always identification of the lesion borders. Make sure you have a stable scope position, and I always apply a soft cap to my scope whenever somebody refers me a large polyp to remove. I think it's just a very good first step. Demonstrate good snare technique, choose the appropriate size and type of snare. Some snares are stiffer, some snares are more bulky and have rough edges. We really want to lay that snare around the target lesion, control insufflation so you're able to bring some of the tissue into the snare. And we feature piecemeal technique. Saline injection with either methylene blue or premixed viscous solution has become our standard of care. You'll want to avoid tissue bridges, and you can treat those with hot biopsy avulsion. I'll show you a case of that. And repeated inspection of the resection site and a soft coagulation to the margins when you're unable to resect them is the standard of care. Assess your risk of perforation at the time, especially if you're using cutting current. I use more cutting current than coagulation current. The duration of the time you push the pedal is important. If you see a target sign, which Michael Bork's group really well outlined this in 2011, I think this should be in your files. If you are a colonoscopist, these are 3 examples of the target sign, which also were correlated with the resection specimen to see the mirror image of that. I think this is just a basic part of endoscopic resection that everyone needs to be quite familiar with. Okay, so large sessile polyps removed with cold snare. You can see here Doug Rex. Nobody does it better than Doug Rex. In the top picture here is the lesion where you can see that the borders are fairly indistinct. This is narrowband imaging, and photo B. After the submucosal injection, you can see the polyps spread out and flatten in image C. What you're seeing here is D is the resection's underway. You can see the target tissue next to the resection specimen with small little blood vessels that are insignificant. All the margins are resected. And then in F, you see a clean resection, no cautery. This is a very low risk of post-polypectomy bleeding or post-polypectomy syndrome in general. For beefier polyps, we tend to use hot snare. This thermal energy allows us to take off a little bit more tissue. And what you can see here in the post-polypectomy area is the polyp was chunked out with cautery margins on the edge. You can see the submucosal layer staining blue still. And then this area right here, this peninsula, is a mucosal bridge that could not be grasped with the snare. This probably was at the base of the polyp, and it was treated with cautery with hot biopsy forceps or the snare tip. I think hot biopsy forceps and avulsion is much more effective than the snare tip, but you can use your judgment on that. And what we see here on the follow-up at 6 months is a nice polypectomy site. I'll take some biopsies from anything that might be appear to be a residual disease, and that way I have the example of the tissue, and then I cauterize that so that we're assessing it as well as treating it. Often I'll find that it's just granulation tissue and the cautery was unnecessary, but you don't know that in advance. So for large polyps, the most important thing for everybody to realize and learn, and I'm still learning myself, is to assess the risk of invasion. So non-pedunculated lesions, the laterally spreading tumor we're talking about here, should be assessed for submucosal invasion in all cases. And if they do have submucosal invasion, my plea to you is just refer for surgical resection. What we're not talking about here are laparoscopic assisted polypectomy or transanal resection. I'm talking about here in this talk, what is the best process for the patients. And if you learn to look for ulcerations and disruption of the pit pattern and vascular patterns, that is by definition non-granular morphology. If you combine that with a depressed lesion, also known as Paris class 2C, or if the lesion, a large lesion, lateral spreading tumor, has large nodules on it, the risk of submucosal invasion is quite high. Now, endoscopic submucosal dissection does have a definite role in achieving a R0 resection in this case. The highest value of this proposition is in the rectum. ESD and the proximal colon really must be balanced with minimally invasive colectomy. And some of you surgeons that are doing laparoscopic right hemicolectomy and getting the patient out of the hospital in 2 days, that's very difficult to compete with on an endoscopic level. And remember, surgery removes field defects common in inherited colorectal syndromes, which could be missed in large patients with large polyps. I generally do not use endoscopic full thickness resection devices, and I think they're fraught with problems. We can go over that in another talk. This is a classic paper. Again, this should be in your file if you're doing endoscopic resection. And Yamada demonstrated here several cases of lesions that had depressed surfaces, topography, and the pit pattern is non-granular. So here, across the top here, in this area here in C, and then here's nodule on top of a laterally spreading tumor, several nodules on top of laterally spreading tumor, and here's several nodules on top of laterally spreading tumor. This is the same paper. It's quite long, it's beautiful illustrations. I picked a few of them that I thought were most representative of the topic here. This nodule here in close-up magnification shows there's no pit patterns here whatsoever. This would be a pit pattern with vasculature. This is no pit pattern. So this would be your non-granular surface. And the representation here in the cartoon is that underneath this lesion is where you find submucosal invasion. And in this picture, it's not quite so apparent that there's a depressed area here, but when you get up close to this, this area here would correspond to these green areas, and this area here that's flat and depressed would correspond to the submucosal invasion. So if we're going to take this out, we're going to use these tools, which many of you are familiar with in submucosal dissection, the submucosal saline injection, using a 10 milliliter syringes at a time. They all have methylene blue, which now has been generally replaced with the pre-viscous products. Have epinephrine on hand. I don't generally put the epinephrine in the solution when I'm doing it myself, but many physicians do. I have no issue with it. There's a mandatory clear friction cap that we showed earlier. It's mandatory to use CO2 insufflation in case you have pneumoperitoneum. and you should only be using a high performance electrosurgical generator that you're familiar with. And then obviously you want to have your hemostatic forceps enclosure devices close at hand. This is the variety of knives that are available, with the newest knife being the scissor type knife, and the coagulation forceps allows you to apply soft coag. And comparing EMR versus ESD, basically ESD provides everything except for a low complication rate, and piecemeal EMR fails to give us deep margins in a significant number of cases, and there's no way for a piecemeal EMR to provide lateral margins. This is the ladder of training. Case selection is paramount. And again, very early on, people should be trying to predict submucosal invasion using chromoendoscopy and high definition. And only after that can you get proficient in EMR techniques. Then after you're proficient in EMR techniques, it's reasonable to start ESD training. There's also the training in histopathologic assessment that's important, and then you can market yourself and account for the extra time applied to some patients for ESD. This is one of our earliest cases that we performed. I did watch cases in Tokyo for about 2 weeks, and then we came back, worked on animal models, typical progression that happened about 15 years ago. The lesion in the rectum are amenable to ESD. You can see it's pretty close to the anal verge. The majority of this was done in the retroflexion position. I prefer the dual knife. You can see here we can cut around the lesion. We can peel it off the submucosal and muscularis propria level. This patient happened to have anticoagulation needs, so she came back within a week with some minor rectal bleeding. You can see here the marginal bleeding does not need treated, but it gave us an opportunity to look at our work, and you can see the granulation tissue that's coming in here. This is not recurrent polyp, obviously. And then 3 to 6 months later, you can see a well-healed scar. I think ESD is very helpful for stubborn lesions. The recurrent adenoma, this one happened to be in the rectum as well. It's very difficult to see. There's some raised areas here, but the lesion goes all the way out to the mid-rectum. On narrowband imaging, getting up a little closer, you can see the pit pattern here of the flat and the raised nodular area. This works well, but they're difficult because they're scarred. You can get into the perirectal fat. This is fairly easily closed with 2 rectal clips, hemostatic clips. And then you can see here at 6 months, the lesion is well healed. There's no evidence of recurrence. A little farther up in the rectosigmoid area, which would be a little tricky for a laparoscopic surgeon to connect with the mid-rectum. This is a 8-centimeter laterally spreading tumor. It does have some elevated nodules, which can be a little concerning for submucosal invasion, but it also can be mucosal prolapse. This procedure went fine. You can see the marking of the margins and then cutting after the submucosal injection, controlled bleeding with the hemostatic forceps. The lesion circumscribed first and then tunneled underneath. Some people were tunneling and then circumscribing. There's also areas of research where traction is very helpful, and all these types of advancements in ESD make it more effective and shorter. This is the same patient. The position's a little bit different because the patient was turned on their back towards the end of the procedure. This is the specimen, about 8 centimeters, and this is what it looked like at 6 months. A nice resection area with a convergence of folds and all scars. This would be an area of interest of mine, the stubborn polyp. This is a transverse polyp. You can see here we have some convergence of folds. This is a depressed area here. I thought I saw some granular features here, but in retrospect, probably not. This is a submucosal injection to assess the lift. It seemed like it lifted, but it was very difficult to grab with a snare, so we switched to ESD techniques pretty early on. You can see the blue solution here in the submucosal layer, but as soon as we got into underneath the depressed area, you can see we ran into fibrosis, and after beating up the lesion with cautery, we decided to stop and send the patient to laparoscopic resection. So what are the things that can stymie you? Well, biopsy the lesion in advance seems to increase the submucosal fibrosis. This is a lesion series of about 272 patients that went for ESD. Of the cohort, 136 had no biopsy sampling because the referring physician recognized that it needed endoscopic resection and they avoid biopsy. They ran into submucosal scar about 10% of the time. Those that were biopsied and sampled, maybe it's possible they looked more advanced because this was not a controlled study, but they ran into submucosal fibrosis about twice the amount of time. So follow up, I think it's very important for 2 slides here to be added to the deck. The first one being the new guidelines want us to recognize that these patients that have multiple or advanced polyps might be part of a syndrome. Any polyp that's larger than a centimeter, serrated polyp, high-grade dysplasia, villus or tubulovillus histology should be followed up within 3 years. And the next slide here dealing with larger lesions that are greater than 2 centimeters. If you can do an en bloc resection, those patients can go for a year and assess safely. That would obviously favor ESD. If you do piecemeal resection, which would be more along the lines of EMR, then we're coming back sooner, especially if there's high-risk histology. If you had to do any macroscopic tissue ablation, like those little bridges that need cautery, those patients should come back in 6 months. If there's no high-risk features, you've been able to piecemeal them out, the patient's polyp was soft, like the Doug Rex image I showed you, those patients are fine to come back in 1 year. And then obviously if they have invasive cancer or any poorly differentiation on the biopsy, they should be referred for surgical resection. So just a few summary slides to wrap it up here. Things to avoid: don't excessively biopsy lesions you plan to refer for endoscopic resection. Don't tattoo lesions in the cecum or rectum. It's never helpful. We always know where the cecum is. We always know where the rectum is. And if they end up having surgical resection of the rectum, those tissue planes are much more difficult to work with. Avoid tattoos in general at, under, or near the lesion. Inject your ink a minimum of a fold away. And in general, don't pierce the colon wall with anything during injection. Start injecting on the way into the mucosa. Make sure you flush the air out, see a little drip of fluid, and then find the submucosal layer on the way in. Don't pierce the colon and find the submucosal layer on the way out. You want to prevent pneumoperitoneum and obviously prevent ink spray of the peritoneal cavity. This is an example of a report that I saw just 2 weeks ago, and I'm just going to point out some of the issues. It looks like this referring physician found at least 4 sizable polyps. The second polyp mentioned here is 4 centimeters. He used spot marker injected for elevation and tattooing. That's a fail. And a snare was used to remove part of the lesion. That's another fail. In the polyp here in the descending colon, the polyp was removed with a hot snare, but it was only 10 millimeters. This one should have been cold snared. And then the last polyp here, 15 millimeters in the transverse colon. He described this polyp as sessile with elongation and stellate. This is usually fold convergence. So right off the bat, this probably had some submucosal invasion, or at least be worried about it. No comment here about pit patterns, granular or non-granular. And the polyp was removed with hot biopsy forceps. There was some residual tissue, so spot marker was injected. This is just, this to me would be not high quality colonoscopy. In conclusion, EMR is extremely effective for laterally spreading tumors of the colon without submucosal invasion. It's the principal method for removing large lesions outside the rectum, in my opinion. Leave polyps alone if you're not capable of removing the entire lesion. In my opinion, ESD is better for en bloc resections. That gives you that R0 resection for early cancers. In my opinion, the value proposition here is best in the distal colon compared to the proximal colon, using surgical standards as our outcomes. And then ESD programs require commitment. There's increased procedural time. There's increased risk of perforation and bleeding. It requires physician skills and assessment of lesions beforehand. It requires team building. And if you're going to take this journey with us, begin in the rectum and progress to other areas. With that, I'll wrap up and thank you for your attention. Hope it was worth your time.